Medical Director of our hospital, Dr. Maribel de los Santos, to be our resource person. Dr. de los Santos is a graduate of UERM College of Medicine. She is an internist and a cardiologist. And as I said, she is the current Vice President for Hospital Services at UERM Hospital. Dr. De Los Santos, you have the floor.
Okay, thank you, sir.
Thank you.
I'm Dr. Maribel de los Santos, and my topic is on patient-doctor relationship and medical economics. At the end of this lecture, students are expected to describe the general overview of the Philippine healthcare system and its economics, correlate the effects of economics on medical practice, discuss the important role of physicians as stewards of healthcare resources, and explain value-based healthcare. The Philippines has a decentralized hospital system setting, wherein the Department of Health serves as the governing agency for both local government units and the private sector, providing services to communities and individuals. The Manila Capital Region and Luzon are the economic heart of the country and also contain the largest share of both public and private healthcare infrastructure. An enormous number of Filipinos rely on public healthcare, yet there is a trend for Filipino medical staff to emigrate to Western countries, which puts the system under strain. As a result, certain hospitals are understaffed, and patients may see a delay in treatment. There is only one physician for every 33,000 people in the country, which is much lower than in other countries. Furthermore, the issue does not only affect doctors. From dentists to midwives, the average practitioner to patient ratio is poor. The distribution of health infrastructure as well as human resources is heavily skewed towards Manila Central Region and Luzon. This physical imbalance is compounded by unequal financial access to health services. This only in the National Capital Region, where physician to patient ratio is near what the World Health Organization desires, that of 10 physicians for every 10,000 population. In Mimaropa, that is Mindoro, Marinduque, Romblon, and Palawan, they have less than 2 physicians for every 10,000 population. Although public hospital staff are highly skilled, public healthcare in the Philippines still has significant geographical disparities. The Philippines' public healthcare system is outstanding in metropolitan areas, yet inadequate in rural areas. The healthcare system relies heavily on private providers. About 30% of the Philippine population uses the private healthcare system as their main source of care. Most hospitals, almost 60%, are also privately owned. The Philippines established the PhilHealth program in 1995 with the goal of providing universal coverage at an affordable price. It is a government-run and government-funded organization, funded by municipal and national government subsidies, as well as company and employee contributions. In addition, the program provides a variety of medical plans based on income, age, and condition. It is estimated that the program covers around 8 out of 10 Filipinos. Government spending on healthcare is limited due to constraints on the government budget. In 2010, a major reform effort was made to achieve universal coverage, reduce payments, and provide more comprehensive cover. Some still remain uncovered, however. Some rural areas only have basic primary health care. With the passage of the Universal Healthcare Act in early 2019, PhilHealth expanded its coverage to include consultations and laboratory tests. In addition, all Filipino citizens will automatically be registered in the national program. The private and public healthcare sectors are linked throughout the country. Health management organizations, or HMOs, provide a wide range of services. HMOs are similar to private healthcare providers. Patients are assigned to certain providers within a network that is based on a system of reimbursement. Most Filipino employees are enrolled in an HMO as part of their employer's benefit package. HMOs and PhilHealth are complementary systems, with HMOs covering costs not covered by the PhilHealth plan. Health spending financed through government schemes and compulsory contributory healthcare financing schemes recorded the largest among sources of health financing in the country, amounting to 409.39 billion pesos or 45.7% of current health expenditure in 2020. Household out-of-pocket payment came second at 400.10 billion pesos or 44.7%, followed by voluntary healthcare payment schemes, which contributed 86.39 billion pesos or 9.6%. A decrease in household out-of-pocket payment was seen in 2020 compared with 2019. On the other hand, an increase in government contribution to healthcare financing was also noted in 2020, an increase of 4% from 2019. Nearly half of Filipinos are unsure if they can pay for their hospitalization if they get sick, according to the second Philippine Wellness Index released in 2019. Initiated by PhilCare, the study found that 40% of 1,350 respondents from various parts of the country expressed uncertainty on their capability of paying medical bills. Moreover, the study revealed that 37% of respondents had to use their savings, while 25% sought the help of their relatives to pay their medical bills. The study also showed that 30% of the respondents were not sure if they can afford the cost of regular medical checkups. Let's now go to physicians as stewards of healthcare resources. Some of you may go into residency once you graduate. As residents, you can do all this, practicing cost-conscious care, avoiding overuse and misuse of diagnostic tests and therapies that do not benefit patient care but add to healthcare costs, avoiding duplication of studies, and being conscious of opportunities to prevent avoidable hospitalizations or readmissions. You will have your own patients to take care of, especially in the service or charity hospital, where patients' financial resources are limited. You have to know at least the cost of the procedures that you want to request for and the price of the drugs or medicines that you want to give your patient. You do not order tests just because they are routine. For example, here comes a 26-year-old student in the OPD who, after a game of basketball, complains of a sprained ankle a few minutes prior. Resident A will put an ice pack on the inflamed ankle, probably give an ibuprofen, and observe. Resident B will request for a CBC because of the inflammation at the ankle area, an x-ray of the foot, and give tramadol plus paracetamol or Dolcet. Patient treated by resident A will probably spend less than 50 pesos for the ibuprofen, while patient B will spend around 400 to 600 pesos. If you were the patient, who will you choose to be your doctor, resident A or resident B? Well, another example is when a patient with bronchial asthma who is admitted for acute attack of asthma and is about to be discharged, a resident in charge of the patient must spend enough time to explain the triggers of an asthmatic attack, what to avoid, and compliance with medications. Educating the patient about his disease is very important in order to avoid frequent readmissions to the hospital, which is very costly. In order to fulfill our role as stewards of healthcare resources, we as physicians should base our recommendations and decisions on patients' medical needs and on the current guidelines from the subspecialty societies or respected organizations. These guidelines are based on randomized controlled trials by respected researchers in the field. Medicines that have proven efficacy based on these trials should be the ones given to patients and not medicines without backup of researchers. Patients will just spend money to buy these medicines that are not proven to be effective. It is a waste of resources. A patient who has a diabetic foot is about to undergo amputation. He informs the physician that he still wants to be active even if he has only one functioning leg. The physician now explains the choices, the level of amputation, the possibility of having a prosthesis or a prosthetic leg after the amputation so that he can still walk. If the patient wants to run in the marathon race, he can still do that. But the type of prosthesis, especially the material the prosthesis is made of, will be different and, of course, more expensive. These are the things that a physician should discuss with the patient, depending on the patient's expectation. Numbers 5, 6, and 7 are all about informing the patient of the different choices or options available in terms of treatment and letting the patient or the patient's family choose the course of action after explaining in detail the advantages, disadvantages, expected side effects or complications, and the cost, a certain procedure or course of action that will entail. For example, deciding whether to give warfarin or the new anticoagulant or NOAC in a patient with deep vein thrombosis who needs anticoagulation entails a thorough explanation since warfarin will entail frequent blood extraction because you want to monitor or determine whether the dose is therapeutic or not. While the latter, that is the novel anticoagulant, does not need any monitoring of its level in the blood. So the patient is spared from frequent blood extraction. However, bleeding, which is an important side effect of both anticoagulants, can easily be controlled when warfarin is used since it has a known antidote in the market. While the novel or the new anticoagulants, some of them don't have any antidote yet. And if there is one, the cost is very prohibitive or very expensive. Another point to consider is the cost of warfarin and the novel anticoagulant. Novel anticoagulant is way more expensive than warfarin. Another example is a patient who needs a coronary artery bypass graft or CABG. Sometimes a cardiologist will only need an electrocardiogram, a 2D echocardiogram, and a coronary angiogram. For some, these tests will be enough, but for others, a nuclear imaging, a thallium scan, or a PET scan or sophisticated blood test are still needed. Sometimes vascular surgeons will just rely on the result of the ultrasound of the carotid artery or carotid artery duplex scan, which is non-invasive. He can already operate on the patient just by the result of the carotid duplex scan. Other surgeons will need an invasive diagnostic test, like the carotid angiogram, prior to carotid artery surgery. It really depends on the physician's level of comfort in making decisions for every patient. Although more tests equate to more expensive treatment plan, sometimes though, these tests are really necessary for better treatment planning in order to have better outcomes. Let's now go to value-based healthcare. Value-based healthcare is a healthcare delivery model in which providers, including hospitals and physicians, are paid because based on patient health outcomes. Under value-based care agreements, providers are rewarded for helping patients improve their health, reduce the effects and incidence of chronic disease, and live healthier lives in an evidence-based way. Value-based care differs from a fee-for-service or capitated approach, in which providers are paid based on the amount of healthcare services they deliver. The value in value-based healthcare is derived from measuring health outcomes against the cost of delivering the outcomes. The benefits of a value-based healthcare system extend to patients, providers, payers, suppliers, and society as a whole. Patients spend less money to achieve better health. Hospitals will have higher patient satisfaction rate since better health outcomes are provided at a lower cost. Risk reduction ensues when unnecessary tests and procedures are curtailed. Suppliers benefit from being able to align their products and services with positive patient outcomes and reduced costs. Society will therefore spend less money in helping people manage chronic diseases and costly hospitalizations and medical emergencies. At a time when improvements of the quality of our healthcare may be uncertain, we bring together interdisciplinary teams that focus on the operational, clinical, and financial tools necessary to successfully implement value-based care models and stay current with the latest guidelines in patient care. Value-based healthcare relies on a concerted effort between members of the medical team in ensuring that procedures to be done on a patient, medications to be given, and other specialists who will come in are all in agreement with the team's overarching goal, that of a better health outcome for that particular patient. Sometimes in the course of treating a patient with complicated disease condition, the attending physician needs the help of other specialists in order to ensure that the patient is being given quality treatment based on expertise of other physicians and not just giving treatments blindly and without direction. That's what happens when a physician tries to avoid referrals to other specialists, even if the patient's condition is beyond his expertise. The challenge now is how to slow the rate of increase in costs while at the same time preserving high value, high quality care. In order to do this, one should also understand what low value care is. Healthcare tends to be more expensive when doctors use new diagnostic tests and procedures that are more expensive. Currently, some surgeons are already using robotic surgery. Precision is enhanced, but of course, procedure is more expensive. Some physicians practice defensive medicine in order to avoid lawsuits. Example is prescribing low-value health tests and procedures like requesting for a cranial CT scan in a 26-year-old female who works as an office secretary who's complaining of headache, or a 36-year-old male medical student who's complaining of chest pain before a long examination, and the patient orders for a coronary angiogram. Low value care leads to unnecessary costs since the tests, procedures, or medicines are not needed in the first place. They are done or given for fear of lawsuits, practicing what we call defensive medicine. A physician who owns a drugstore or a CEO of a pharmaceutical company will tend to prescribe medicines that he is selling, even if the drugs from other companies are more effective or backed by research studies. It has been noted that more than 70% of physicians are more likely to perform unnecessary procedures when they profit from them, like requesting for a 2D echocardiogram left and right, when that physician is the owner of a 2D echo machine, or where a physician, when a physician has his own electrocardiogram machine or ECG machine in his own clinic. Simply put, low-value healthcare exposes a patient to unnecessary risks and, of course, unnecessary expense, making healthcare unnecessarily expensive, which is completely the opposite of high-value care, which results to improved health, elimination of wasteful practices, and most of all, avoidance of unnecessary risks or harms. Remember that in the practice of prudent stewardship of healthcare resources and value-based healthcare, more treatment is not always better treatment. For example, in a 20-year-old male who's complaining of headache, giving pain reliever like paracetamol may be enough. In fact, sometimes you don't have to give anything. If you'll just get a detailed history and a thorough physical exam. Sometimes the problem lies in prolonged exposure to computer resulting to muscle strain in the cervical area and eye strain, producing headache. Decreasing the amount of time in front of the computer will usually resolve the headache. Some physicians feel insecure when they don't prescribe medicines to patients because the patient might feel that he is not a good doctor because there is no prescription. Not giving medicine at all is already part of the treatment. expensive treatment is not always better treatment. There are some physicians that give medicines that are expensive when there are less costly medicines that are available and equally effective. Best example here is prescribing branded medicines over generic ones. We all know that generic medicines are way more cheaper than branded ones. One must understand that branded medicines are more expensive because pharmaceutical companies have to spend a lot of money in marketing. And the cost of these marketing strategies is included in the cost of these branded medicines. That's why they're more expensive. And lastly, the newest treatment is not always better. Some physicians go with what we call the new kid on the block, just to be updated with while other physicians tend to stick to the ever reliable medications or medicines that they have always known to produce the same results. Sometimes these new treatments are more expensive than the old equally effective drug. And in value-based care, remember that better health outcome is what we always aim for. This is my last slide. Thank you for your attention. Okay. Share. Okay, the floor is now open for questions from the audience. By the way, I'd like to correct one of my slides earlier. HMO means Health Maintenance Organization, not Health Management Organization. No? And no question yet. You can write you can type your question in the chat box. No? I'll be happy to answer them. So there's one question here. Would you have any suggestions on how to keep our healthcare professionals serving in the country? Wow, that's a $1 million question, Regina. And I of the same mind that healthcare professionals should stay for example the nurses, no? We have a lot of nurses that are in demand in other countries simply because Filipino nurses, they say, are more caring than the other foreign nurses. So we have a lot of nurses going to other countries. So it's one of the problems right now being faced by the healthcare industry. In our hospital, we lack around 31 staff nurses. The same is true with other hospitals in the country and worldwide. There's a need for staff nurses, no? For doctors, same is true. They want to go there, number one, to further study, to further hone their craft, no, for specialization. But I do believe they usually come back, no, after specialty, after postdoctoral specialty in other countries. How would you any suggestion? Actually, we already suggested that one of the reasons why nurses go to other countries is, of course, the big difference in salary of nurses here and in other countries. but the government will not all. For the hospital, for example, URM hospital cannot increase their salary like that in the government hospital. Malulugi tayo, magsasara tayo. Hindi natin kaya yon, no? So, yeah, it's one of the pressing problems right now. The brain drain, no, of healthcare professionals. Thank you for that question, Regina. I'd like to inform the group that the UERM hospital, the one that you'll be going to when you go to second year, third year, fourth year, and postgraduate internship, and then residency, is a teaching hospital. In fact, we have more patients in the teaching hospital compared with the pay hospital. No? We have two types of hospitals here in South Campus. The academic side is the North Campus. And sometimes, or more often than not, poor people or indigent people really cannot afford the necessary tests that they need, no? And due to this, we have what we call the Educational Resource Development Fund, no? Formerly called the Medical Indigency Fund. Uh, the objective is to help finance the much needed test that the patient confined in the teaching hospital cannot afford, but very much needed, no? Especially those interesting cases. For example, if a patient is admitted in the neurology ward, and the diagnosis is stroke or impression is stroke, a CT scan is a must, no? And we have our CT scan here. A cranial CT scan is a must. So the the hospital can cover for that, no? To, of course, for better health outcomes, because through the CT scan, the neurologist will be able to manage adequately the type of stroke the patient has, because the management is really very different if the stroke is hemorrhagic and if the stroke is ischemic infarct. So that's why CT scan is a must when your diagnosis is cerebrovascular accident or stroke. Any other question or clarification? Once you go into fourth year, your clinical clerkship year, that's fourth year uh, in medicine, you will have your own patient. Your 365 days are spent in the hospital. You don't have lectures in the North Campus. All your days are spent in the hospital, no? When you become 40. Then you have your own patients, especially in the service hospital or teaching hospital and in the outpatient. We have a lot of outpatient in our Pio Domingo outpatient clinics, where our service patients usually sick consult, no? And you are the first line there, no? Patients usually go to you for consult. That's why having these concepts in medical economics is really important. You can already practice medical economics, stewardship, during this period in your medical life. No question? If you have question later on, you can approach me. I'm here in the hospital every day, anytime. No?
Okay, so walang questions.
So wala nang questions, sir.
Okay, sige, thank you, Dr. De Los Santos.
Ipo,
And for
thank
the
you.
rest, yeah, for the rest of the class, you are dismissed. God bless. Take care. Bye-bye.
Ay, Doc, thank you po.
Thank you, Doc.
Thank you po, Doc.